Dr. Vinita. Next, we have Dr. Kavitha. She's a well-renowned pediatric ophthalmologist. She is the editor of the Karnataka Ophthalmic Society as well. So, over to you, Dr. Kavitha.
I would like to thank KSOC and Dr. Samira and Dr. Srini for this opportunity. I have no financial interest in this presentation. As all of us know that visual acuity improves rapidly during the first year of life and goes on developing and matures by the age of approximately 5 to 6 years. Neonates are normally hypermetropic. They have a diopter of plus power of about 4 diopters and with a minimal astigmatism of 2 diopters. So anything like between 2 and 3, we shouldn't be really jumping and prescribing glasses or get panicked about it. With increasing age, hypermetropia and astigmatism do decrease gradually. Emmetropoization is completed by 7 to 8 years of age. The correction of emmetropia in children is quite challenging because of the low cooperation that we get from these children, and there's a risk of amblyopia, and role reliability is an important factor, and most importantly is the convincing the parents to make them understand that the child has refractive error and it needs glasses. And prescribing visual correction for children has two goals, that is to provide a focused retinal image and achieve an optimal balance between accommodation and convergence. This is quite essential and important to establish as early as possible. What are the indications for refraction? Either the parents come with the complaint that the child is not able to see, or as an abnormal gaze or abnormal head posture or abnormal looking eyes, and sometimes parents do pick up the presence of squint, and nystagmus is quite obvious. So all these indications or conditions present at younger children is an indication for refraction. Just briefly on the types of pediatric refraction is first is the objective and the second one is subjective. Subjective is little difficult in children less than 5 years. Sometimes children do cooperate between 4 and 5 years. It's worth trying, putting in effort and trying. We have to look at the keratometry reading. You can possibly do a ARK, and retinoscopy proper has the dynamic retinoscopy and static retinoscopy. Dynamic is actually nothing but the near retinoscopy, where we actually assess the amount of accommodation that is there. And static, either you do dry, and most of the time it is the cycloplegic retinoscopy that we have to consider in children. In some young patients, subjective refraction may be impossible, so hence a cycloplegic refraction and retinoscopy is a gold standard procedure. Now let us look at the various cycloplegics that we have to consider in children. The first is atropine, and we know it has longest duration of action, and the onset of action is also pretty late. It takes about 36 hours. And invariably with squint, we use this ointment 3 times a day for 3 days, and then we refract later. The other alternative to atropine is the homatropine, which the effect, of course, starts off by 1 hour. But with the squint, I once again use it for 3 days and 3 times for both eyes. And duration of the effects last for about 3 to 4 days. And cyclopentolate is for older children. The duration of onset of duration is like 2 days, 2 to 3 days. Anyway, if you want to do a post-mediatic test, better to do after 3 days. And the other drug is the tropicamide, which you can use it in older days. Here we need to understand what we have to deduct is for the distance, it's about 1 to 1.5 diopters. If you are doing refraction at 1 meter, then you deduct it by 1 diopter. If it's little lesser than that, you can deduct it by 1.5 diopters. Then you need to also deduct for the cycloplegic drug that you are using. For atropine, it's about 1 to 1.5 diopters, and for the others, you can have an average of 0.5 to 0.75 diopters. AO has these guidelines, rough guidelines. So, which one to use in what age? And the other thing that you have to consider is whether the child is having associated squint, that is esotropia. So, less than 2 years, all children you use with or without esotropia atropine 1%. And between 2 to 5 years, you can shift to cyclopentolate if there's no esotropia, but with esotropia, better to do a atropine refraction. Between 5 to 8 years, it's once again cyclopentolate with esotropia, or you can shift to tropicamide. And with or without, I mean, wherever there is squint, better to go for cyclopentolate or atropine or homoatropine. But otherwise, you can shift to tropicamide for children above 8 years. There are various charts to assess the visual acuity. I'm not going in detail regarding this, but above 3 years, we can try the Snellen charts, HOTV chart, Tumblingi, and Logmar chart. For children less than 3 years who are not cooperative for refraction, you can think of an OPD procedure, that is sedation under oral syrup. Pedicloral syrup is what I use, and it's half the dose. The weight, first you measure the weight of the child, and then half the weight you can give that syrup. Or if really uncooperative children, you can think of examination under short general anesthesia. And less than 5 to 6 months, I do think of ROP drops, which is a diluted tropicamide plus. A streak retinoscopy and the lens stack is very convenient because all these lenses are in one row, and you can sequentially just jump from one lens instead of changing the lenses, which is there in the trial set. A portable ARK is very useful in understanding what is the post-cycloplegic refraction. These are the various portable ARs available in the market. I have no financial interest. I usually use the NIDEC and the Orolab AR. They do give reliable results, but frequently we need to calibrate this with the company people so that we get the same readings over a period of time. When to prescribe the glasses? Yeah, we do follow AO guidelines, but later eventually you start having your own sense of discretion, when to give and how much to give. And also, if possible, wherever subjective refraction comes into play, I think the age is an important factor. Above 5 years, most children do allow for subjective correction. Only thing that we need is patience. So coming to myopia, infants and toddlers with myopia of greater than 4 diopters, you think of it, and aim to prescribe the lowest minus power that required for best visual acuity. Hypermetropia greater than 5 diopter can result in asthenopia, and full cycloplegic correction is given in children with esotropia. And bifocals have to be given for children with esotropia with high AC by A ratio. So this near add which is given takes care of the near deviation. Now coming to astigmatism, as earlier we were under correcting, it's no more required. You can give full cylindrical correction.
Can we conclude faster, madam?
Yeah. Anisometropia, any power greater than difference of 1.5 diopters, you can think of prescribing. This is the AO guidelines for isometropia, for myopia, anything above 3, hyperopia, anything above 4, and astigmatism, anything greater than 2, you can think of prescribing. Needless to say, duochrome test has to be done, check on the cylinder, and most importantly, binocular balancing is important. In aphakics, additionally, for children less than 2 years or 3 years, you think of additional add of +2, and above 3 years, you can think of bifocals. Pseudomyopia is yet another condition where you have myopia before cycloplegic refraction, but post cycloplegia, there is a hypermetropic shift. So you'll have to look for the factors that is really causing the pseudomyopia. Spectacles have to be well fitted, comfortable, well centered, and should not hamper the natural development of the nose. This care has to be taken while prescribing the glasses. Now coming to the last slide, the do's is age appropriate vision charts have to be considered. Appropriate cycloplegic agent has to be used. PMT has to be done whenever required. Full cycloplegic correction for hyperopia with esotropia. Full correction for hyperopia, myopia, and astigmatism. And children with cylinder greater than 2 diopters, think of topography and pachymetry to rule out keratoconus. A regular follow-up is mandatory. Don't undercorrect in myopia and astigmatism. When in doubt about refraction, don't prescribe glasses. It's better to do PMT. Watch out on pseudomyopia and over or undersized or tight frames and decentered glasses.